Okay, this is from the book John McDougall, The Doctor Who Fought for You by me, Pete Rogers. We're on part 3 of heart disease. And you can correlate and estimate the likelihood a patient will have more than 50% narrowing, stenosis of the coronary arteries. These are for people under 40 years, so these are young patients. If their total cholesterol is less than 200, only 20% of them will have more than 50% stenosis, partial blockage in their coronary arteries. Like, and we're talking about the epicardial coronaries, of course. Left main, left anterior descending, left circumflex, right coronary. Okay, if their total cholesterol is 226, 250, about half of them will have 50% or more blockage. That's a lot. Okay, if they're over 300, 80% of them will have a blockage. All right, so total cholesterol is a very important thing. There's all kinds of nonsense on the internet trying to tell people cholesterol doesn't matter. That's wrong. It does get more confusing when patients have been partially treated with statins and other lipid lowering drugs. Okay, but if you can do it just by diet alone, keep it below 150, 140, you're in good shape. Okay, let's scroll up a little bit here. To convert total cholesterol from milligrams per deciliter to IU, you can divide by 38. Okay, elevated blood cholesterol is a risk factor, not a disease. You can get a blood test for total cholesterol for only about $10. It's true that sometimes a person has a high cholesterol but clean arteries, or even the opposite. But a relatively normal cholesterol that has atherosclerosis is not that common. Okay, so it's useful. It's not always 100% accurate, but it's useful. And you can also have microvascular disease and have clean, epicardial coronaries, the big ones on the outside of the heart. The clinical goal is to get your total cholesterol below 150 because persons below 150 have a very low incidence of coronary artery disease. To be below 150 is the ideal level of total blood cholesterol, and he would go by total blood cholesterol. Pritikin was even more strict. He would like it to be below 140. Okay, inflation of a balloon in a coronary artery is called balloon angioplasty. The medical abbreviations are PTCA, that's percutaneous transcatheter angioplasty. Some would use the abbreviation POBA, plain old balloon angioplasty. I can tell you most of the time nowadays they call it PCI, percutaneous coronary intervention, and that usually means a stent. Okay, coronary artery balloon angioplasty was invented by Andreas Roland Grünzig, a German doctor. Grünzig encountered obstacles to practice in Germany, so he moved to Switzerland. And cardiologists started performing balloon angioplasty in the coronaries in the late 1970s, but they ran into problems of distal embolization. Parts of the plaque would break off and go distally and could block arteries there. You could potentially break the arterial wall. I had a relative, one of my uncles, who died from a coronary artery dissection during a cardiac cath, a routine diagnostic cath. So it's a serious thing. The embolized pieces of plaque can float distally and include arteries. Oh, one point I'd like to make too is if you go to Wikipedia and you look up Andreas Grünzig, the inventor of balloon angioplasty, there's this big long discussion of him. He's this big medical hero. It's this wonderful celebration. But the reality is balloon angioplasty and stenting doesn't increase longevity at all, like a big zero. On the other hand, low-fat vegan diet has dramatic improvement in treatment of coronary arteries, but you won't see all this laudatory praise. In Wikipedia, they slander Dr. McDougall, okay? And they very often slander anybody who's not selling drugs or surgeries, things that make money for the establishment, conventional medicine. They get slandered. And then somebody who does help them make money, like Grünzig stents, make a lot of money. You pay $30,000 a stent. He's a big hero in Wikipedia. There really ought to be an alternative publication. I'm not aware if there's any significant ones. Okay, then the cardiologists developed bare metal stents, BMS, to smush the atherosclerotic plaque against the arterial wall. A BMS is like a soda pop can. You can cut it like you cut out the top and the bottom of it. The walls of the BMS are porous, like a chain link fence with small holes. One of the biggest problems with the BMS is that the arterial wall continues to proliferate and can grow into the stent, and this can occlude the stent. With bare metal stents, about 40% of arteries are closed down within a year. So the cardiologist developed a new stent called a DES, drug-eluting stent. The drug-eluting stent contains drugs that are like chemotherapy to prevent the local arterial wall from growing into them. The drugs dissolve out of the stent and they go into the arterial wall to prevent it from proliferating. The drug-eluting stents prevent the arterial wall from proliferating. However, the DES chemo drug only lasts about 4 months. The patient's put on blood thinner drugs to help prevent the blood from clotting. The typical oral drug therapy to prevent clotting, something like dual antiplatelet therapy, often abbreviated DAPT, with aspirin and Plavix. DAPT reduces the risk of coronary artery clot formation, but increases the risk of bleeding elsewhere. Okay. Placement of stents from percutaneous approach is usually done by entering the right common femoral, right in the groin on the right. Placement of a stent into the coronary arteries is called a PCI, percutaneous coronary intervention. Billing is typically about $30,000. And coronary artery stenting has been very popular for decades because it's profitable. Superficial inspection, it seems to be logical. Let's open up the artery like a plumber would open up a pipe. It's fun for the interventional cardiologist. They enjoy doing these procedures. The patients are, in a sense, kind of self-referred from one cardiologist to another cardiologist. The public assumes that all the doctors are the same and that they are in good hands. In reality, this is Dr. Mcdougall's article here, the results of PCI are surprisingly variable. From the Journal of Circulation, 1983, an official journal of the American Heart Association, coronary arteriography and coronary artery bypass surgery, morbidity and mortality in patients 65 and older. If a person has chest pain, that might be a heart attack, they should immediately go to emergency room. And if the cardiologist performs PCI within 90 minutes of onset, they can often reopen the artery and save the patient's life. Even within 6 hours of onset, it can potentially be beneficial to reopen the artery and save a significant amount of cardiac muscle. The problem with coronary artery stents is that they don't work well for the much more common problem of cardiac angina with coronary artery atherosclerotic stenosis. That's what the vast majority of patients have. Journal of the American College of Cardiology, successful recanalization of native coronary artery total occlusions is not associated with improved long-term survival. Successful PCI versus failed PCI was not associated with a decreased risk of mortality. Okay, coronary intervention for persistent occlusion after MI, the OAT trial. PCI did not reduce the risk of occurrence of death, reinfarction, or heart failure, and there was a trend towards excess reinfarction in 4 years followed. So what this is Mcdougall's collected the papers, and what he's showing you is that stenting really doesn't make much difference, okay? It's not going to make you live longer other than in the setting of an acute myocardial infarction. So what I'm trying to say here is, do you understand this? It's kind of a big joke. All you got to do is eat a low-fat plant-based diet, and you don't get all this crap. You don't have to go through this stuff, okay? But if you don't, you get a stent for $30,000, and then you're still going to have to take all these blood thinner medications, and it doesn't increase your life at all. So why would you go down that route? It's a stupid thing to do. Okay, continuing. Percutaneous coronary intervention versus optimal medical therapy, systematic review, 7,100 patients. PCI compared with OMT, optimal medical therapy, showed that PCI did not reduce the risk of mortality, cardiovascular death, non-fatal myocardial infarction. So I think that's funny, optimal medical therapy. When they say optimal medical therapy, they just mean drugs. They don't mean diet. So optimal medical therapy is also a joke. So what they're basically saying is they're equally crappy, optimal medical therapy and percutaneous coronary intervention. Okay, now we're going to talk about CABG. CABG means coronary artery bypass graft. It's open heart surgery for treatment of atherosclerosis in the arteries of the heart. CABG is an absolute failure. Mcdougall's words, it's an absolute failure because it treats the wrong lesion. CABG treats the hard, fibrous, non-lethal plaques or scars, which never kill you. The cardiologists and the cardiac surgeons cannot see the tiny, volatile plaques, pustules, that eventually rupture and kill the heart muscle. The culprit lesions, the ones that might actually progress to occlude a coronary artery, are left untouched. And that's why CABG does not prolong life, except for rare circumstances. So what Mcdougall is just systematically pointing out why the surgery is kind of a big joke. And that's why I always laugh when people say, well, you need to pay attention to the science. Yeah, the science is advertising. Okay, Mcdougall continues. The 3 big studies, and there's only these 3 big studies on heart surgery, CABG, show that it lacks survival benefits. First study here, 5-year survival rates for surgery, 82% medical therapy, versus 82% versus medical therapy 80%. So no difference in survival for medical therapy versus surgery. But you go through a lot of morbidity with surgery. You know, they got to take a buzzsaw down the middle of your chest. They got to harvest a vein from your leg. It's no fun. They got to take the lima to the LAD, left internal mammary artery, to the left anterior descending artery. It's a big deal. Okay, the CAS study. CAS study is 5-year survival for surgery is 95%. Now that's pretty good. For medical therapy, 92%. And one must remember that the surgery comes with great financial cost, pain, suffering, risk of complications, and death. Okay, so the bottom line, the point of all this was no significant benefit from open heart surgery or stenting for increased longevity, duration of life. You do get some symptomatic relief from cardiac angina with the stent or the surgery, but you get a lot of morbidity. So the bottom line is a smart person would just eat the low-fat, low-sodium vegan diet with no oil and just keep the arteries open. Why go through all this? Okay, we'll end it there for part 3. Well, next one we'll do part 4 on heart disease.